Acute coronary syndrome is a collective term used to denote any set of clinical symptoms indicative of acute myocardial ischemia, encompassing unstable angina, non-ST elevation MI, and ST elevation MI. In this presentation, we will discuss high-yield key points on non-ST elevation MI and unstable angina. A 58-year-old female presents to the emergency department with complaints of chest pain that started about 45 minutes ago. She describes the pain as squeezing in nature, located retrosternally, radiating to her neck and left arm. She has a past medical history significant for hypertension and diabetes. On physical examination, her blood pressure is 150 over 90, heart rate 100, respiratory rate 18. Cardiac auscultation reveals normal S1 and S2 with no murmurs, rubs, or gallops. EKG shows ST segment depression in leads 2, 3, and AVF. Troponin levels are within normal limits. What is the most likely diagnosis? Stable angina, myocardial infarction, unstable angina, Prince-Meadows angina, or pericarditis. The correct answer is unstable angina. Unstable angina is characterized by new onset angina, increasing frequency or worsening severity of angina. It typically occurs at rest or with minimal exertion and is not relieved by rest or nitroglycerin. EKG changes may include ST segment depression or T wave inversion, but the troponin levels are typically normal or minimally elevated. In this patient, the presentation of chest pain at rest, radiation to the neck and left arm, along with ST segment depression on EKG, are consistent findings with unstable angina. A 64-year-old male patient presents to the emergency department with complaints of chest pain that began about 2 hours ago. He describes the pain as squeezing in nature, located retrosternally and radiating to his left arm. He has a past medical history for hypertension and hyperlipidemia. On physical examination, his blood pressure is 160 over 90, heart rate is 90, respiratory rate 18. Cardiac auscultation reveals normal S1 and S2 with no murmurs, rubs, or gallops. EKG shows ST segment depression in leads V2 to V6. Troponin levels are elevated. What is the most likely diagnosis? Unstable angina, stable angina, non-STEMI, STEMI, or pericarditis. The correct answer is NSTEMI. NSTEMI is characterized by chest pain at rest, new onset angina, worsening angina, or angina that occurs with minimal exertion, along with an elevated cardiac biomarkers such as troponin in the absence of ST segment elevation on EKG. This condition is often associated with partial occlusion or transient thrombus formation in one or more coronary arteries. In this patient, the presentation of chest pain with ST segment depression in leads V2 to V6, along with an elevated troponin levels, is consistent with NSTEMI. Troponin elevation confirms myocardial injury. On the other hand, unstable angina is similar to NSTEMI in terms of clinical presentation, but it is defined by normal cardiac biomarkers such as normal troponin in the setting of ischemic symptoms. In this case, the elevated troponin level indicates myocardial injury, making NSTEMI the more likely diagnosis. Stable angina, which is the option B, usually presents with reproducible chest pain at least 2 months duration that occurs with exertion or emotional stress and relieved with rest. Compared to STEMI, which is option D, is characterized by persistent ST segment elevation on EKG, which is not seen in all leads in this case. Pericarditis, option E, may present with chest pain, but the chest pain is sharp, severe, and positional. It is worse in a supine position and improves with sitting up and leaning forward. It is possible that troponin may be slightly elevated due to myopericarditis, but the EKG finding shows a more diffuse ST segment elevation versus ST elevation MI, which has more of a localized ST segment involvement. Unstable angina is more of a supply and demand mismatch, leading to myocardial ischemia, but not related to myocardial infarction. There are generally three main presentations of unstable angina: rest angina, new onset severe angina of less than 2 months, and increasing angina, increasing intensity, duration, and or frequency. Non-ST elevation myocardial infarction is also a supply and demand mismatch and is associated with a non-transmural subendocardial infarct. It typically manifests as prolonged, intensified rest angina or anginal equivalents. Specifically, these forms of acute coronary syndrome vary in the severity of ischemia, leading to myocardial necrosis and subsequent release of biomarkers such as troponin due to its associated myocardial injury. NSTEACS is the acronym for Non-ST Elevation Acute Coronary Syndrome. It is caused by partial occlusion of the artery and presents with ST segment depressions and or T-wave inversions. Most patients with NSTEACS will develop acute myocardial infarction, which is NSTEMI. Patients who do not develop infarction is classified as unstable angina. A 58-year-old female with a history of hyperlipidemia and smoking presents to the emergency department with chest pain that started 2 hours ago while she was walking her dog. The pain is described as squeezing and sensation behind her sternum, radiating to her left shoulder, and is accompanied by shortness of breath and sweating. On examination, her blood pressure is 145/85, heart rate 95, respiratory rate 22. Her EKG shows no ST segment elevation, but demonstrates T-wave inversions in the lateral leads. Initial troponin level is elevated. Which of the following is not the most appropriate initial management for this patient? Beta blocker, aspirin, nitrates, statin, or thrombolytic therapy? The patient in this case has a non-ST elevation MI. Thrombolytic therapy is not indicated in non-ST elevation MI as the risk of bleeding outweighs the potential benefits in the absence of ST segment elevation myocardial infarction. Initial management for non-ST elevation MI and stable angina includes aspirin, beta blocker, nitrates, and high-intensity statin. If there is persistent chest pain despite beta blocker therapy and sublingual nitroglycerin, IV nitroglycerin can be given to alleviate the chest pain. Avoid choosing IV nitroglycerin if the patient does not have any chest pain. If the patient has contraindications to beta blockers or has persistent chest pain despite nitrates and beta blockers, consider a non-dihydropyridine calcium channel blocker, such as diltiazem and verapamil in STEMI or unstable angina, but has no benefit in ST elevation MI. If a patient presents with NSTEMI or unstable angina with hypotension, ongoing chest pain, heart failure, or ventricular arrhythmias, the next best step is urgent invasive treatment. The choice of this is either a PCI or a CABG, and this really depends on the coronary angiography result. The main indications for CABG includes multivessel coronary artery disease or a left main coronary disease, since CABG has been shown to be associated with better outcomes and more complete revascularization in this situation. On the other hand, if the patient with NSTEMI or unstable angina is hemodynamically stable, a risk assessment is indicated to select the type of treatment strategy. The TIMI score and the GRAY scores are the most popular and validated ACS prediction models. They are used to help guide decision to pursue an invasive versus ischemia-guided approach. TIMI risk score predicts 14-day death, recurrent MI, and urgent revascularizing rates. The TIMI risk score includes 7 independent predictors for death, non-fatal myocardial infarction, or ischemia requiring revascularization at 14 days, with 1 point assigned for each of the following predictors: age 65 or older, 3 or more CAD, risk factors like cholesterol, family, history, hypertension, diabetes, or smoking, previously documented CAD with stenosis of at least 50%, aspirin used in the last 7 days, 2 or more ischemic episodes in the past 24 hours, ST segment deviation on EKG, and elevated cardiac markers. The GRACE risk score includes examination findings, clinical features, EKG findings, and lab results to predict death and MI. Out of the two risk stratification, the TIMI score is widely used than the GRACE risk score. If the patient is at high risk, TIMI score of 5 to 7, or gray score 141 to 372, then early invasive strategy is recommended. The strategy is performed within 24 hours and includes the following: dual antiplatelet with aspirin plus either clopidogrel or ticagrelor, anticoagulation such as enoxaparin, unfractionated heparin, or fondaparinux. Anticoagulation is associated with reduced reocclusion of the infarct-related artery with better outcomes. Urgent immediate diagnostic coronary angiography within 24 hours. Then PCI or CABG based on the coronary angiography findings. If the patient is at intermediate risk, then delayed invasive strategy is recommended. The strategy is performed within 25 to 72 hours and includes the following: dual antiplatelet with aspirin plus clopidogrel or ticagrelor, anticoagulation therapies such as enoxaparin, unfractionated heparin, or fondaparinux, and then an urgent or immediate diagnostic coronary angiography. If the patient is at low risk, TIMI score of 0 to 2, or a gray score of 1 to 108, then ischemia-guided strategy is recommended. This strategy includes, again, dual antiplatelet of aspirin plus either clopidogrel or ticagrelor, anticoagulation like enoxaparin, unfractionated heparin, or fondaparinux, and a non-invasive stress testing. If the patient is at low risk or has a normal stress test and the patient has no chest pain, the patient is then discharged from the hospital. However, if the stress test is abnormal or the patient has recurrent chest pain, the next best step is a coronary angiography, and then a PCI or a CABG is performed if there is indication. After the patient has been stabilized and before discharging, the patient should be given 1 year duration of dual antiplatelet therapy that includes aspirin plus clopidogrel or ticagrelor. A 72-year-old male patient with a history of prior myocardial infarction, diabetes mellitus, and peripheral arterial disease presents to the emergency department with severe chest pain lasting for 6 hours. The pain is described as constant, heavy sensation in his chest with radiation to his left arm. He appears pale and diaphoretic. His vital signs are blood pressure 100/60, heart rate 100, respiratory rate 24. His EKG shows ST segment depression in leads 2, 3, and AVF. Initial troponin level is significantly elevated. Based on his presentation and history, he is assessed to have a high TIMI score for NSTEMI. He was started on aspirin, clopidogrel, and enoxaparin. What is the most appropriate next step in the management of this patient? Echocardiogram, oxygen, perform immediate coronary angiography, or begin thrombolytic therapy? The correct answer is C. Perform immediate coronary angiography. Patients with a high TIMI score for NSTEMI are at increased risk for adverse cardiac events. This patient, with his age, history of prior myocardial infarction, diabetes, peripheral arterial disease, clinical presentation, EKG changes, and an elevated troponin level, likely has a high TIMI score. Immediate coronary angiography is recommended in high-risk patients with NSTEMI as it allows for rapid diagnosis and management of coronary artery blockages, potentially including a PCI or CABG if necessary. Echocardiogram can identify patients who might need further invasive assessment, but is not the most appropriate next step in patients with a high TIMI score. Supplemental oxygen is part of supportive treatments, but do not address the underlying cause of the myocardial ischemia in a high-risk NSTEMI patient. Thus, they are not sufficient as a standalone treatment. Thrombolytic therapy is generally not indicated in NSTEMI due to the lack of ST segment elevation and the risk of bleeding. A 50-year-old female with no significant past medical history presents to the emergency department with chest discomfort for the past 8 hours. She describes the discomfort as mild, intermittent pressure sensation in the center of her chest without radiation to other areas. She denies any previous episodes like this and has no family history of coronary artery disease, and her only risk factor is a history of smoking. On examination, her blood pressure is 130 over 80, heart rate 70, respiratory rate 16, and her oxygen saturation is about 98%. Her EKG shows no ST segment changes or T wave changes. An initial level troponin are slightly above the normal limit. She is diagnosed with a suspected non-ST elevation MI. She is on aspirin, clopidogrel, and enoxaparin. Considering a low TIMI score for this patient, what do you think is the most appropriate next step in her management? Immediate coronary angiography, high-dose statin therapy and lifestyle modification, admission to the intensive care unit for monitoring, stress testing during the same hospital admission, or immediate administration of thrombolytic therapy. The correct answer is D, stress testing during the same hospital admission. The TIMI score for NSTEMI assesses risk based on age, known CAD, use of aspirin in the past 7 days, at least 3 risk factors for CAD, significant anginal episodes in the past 24 hours, ST segment deviation, and elevated cardiac markers. Given her relatively young age, absence of significant past medical history, and only one cardiac risk factor, which is smoking, this patient likely has a low TIMI score. Stress testing during the same hospital admission is appropriate for patients with a low risk NSTEMI. This non-invasive testing can help stratify her risk and determine the need for further invasive interventions like coronary angiography. Immediate coronary angiography is typically reserved for high-risk patients or those with dynamic or persistent ischemic changes, hemodynamic instability, or refractory angina. High-dose statin therapy and lifestyle modification are essential parts of long-term management, but are not immediate priorities in the acute hospital setting. Admission to the intensive care unit is for high-risk patients requiring close monitoring and potential urgent interventions. Thrombolytic therapy is not indicated in NSTEMI, especially in the absence of ST segment elevation and in low-risk patients. Now let's discuss some rapid-fire key points. Unstable angina has EKG changes that might include ST depression or T-wave inversion but normal troponin. And STEMI has EKG changes except for ST elevation with high troponin. Troponin elevation confirms myocardial infarct. Normal troponin with EKG changes is associated with myocardial ischemia but not myocardial infarction. Initial management includes beta blocker, aspirin, nitrates, and statin therapy. IV nitroglycerin is added if the patient has persistent chest pain. Calcium channel blocker is added if the patient has contraindications to beta blockers or has persistent chest pain despite being on beta blocker and nitrates. Urgent invasive treatment, such as angiography, then PCI or CABG, is indicated if the patient presents with NSTEACS with hypertension or ongoing chest pain or heart failure or ventricular arrhythmias. If the patient is stable, risk assessment is performed, either a TIMI score or a GRACE score. A high TIMI score requires early invasive strategy within 24 hours that includes urgent or immediate diagnostic coronary angiography, then PCI or CABG. A low TIMI score suggests more of an ischemia-guided strategy, and that does not include coronary angiography, but includes non-invasive stress testing. Thank you, and I hope you enjoyed our high-yield key points on NSTEMI and unstable angina.